All right. Good evening, distinguished colleagues, esteemed participants, ladies and gentlemen. On behalf of Public Service Knowledge Hub, I warmly welcome you to today's knowledge sharing session. Our discussion today reminds us that public service is not limited to policy formulation alone. It is about translating policies into meaningful outcomes that improve the life of our citizens. As public servants, each of us has a role to play in advancing maternal and child health and supporting the achievement of sustainable development goal toward in Lagos State. I am confident that today's session will broaden our perspective and inspire practical action within our respective MDAs. Thank you for making time to be here. So on this note, I will call on our moderator to kickstart the program. Moderator, are you still with us?
Yes, I'm here, sir. Good evening, sir.
You have the floor.
All right. Good evening, distinguished ladies and gentlemen. Our distinguished colleagues, and I welcome you all to another impactful session of the Public Service Knowledge Hub. On today's session, we'll be exploring a topic that speaks not only to the health sector, but to the responsibility of every public servant in contributing to the well-being and development of our society. Our topic for today, from policy to practice, the public servant as a catalyst for maternal and child health in Lagos State's pursuit of sustainable development goal 3. When we talk about maternal and child health, it is easy to assume that the responsibility rests solely with doctors, nurses, midwives, and other healthcare professionals. But today's topic challenges us to look beyond that perspective. Every public servant, regardless of cadre, department, or area of specialization, has a role to play in translating policies into meaningful outcomes for citizens. As public servants, the policies we develop, the programs we implement, the resources we manage, the services we deliver, and even the decisions we make can have direct or indirect impact on the lives of mothers and children. So this session provides us with an opportunity to reflect on the gap between policy and practice, understand the challenges surrounding maternal and child health, and most importantly, consider how we can individually and collectively become more informed advocates and practitioners in advancing better health outcomes. And to take us through this very important conversation, we have with us someone who is quite well positioned to lead this discussion. Mrs. Rashidat O. Sonny, health educator with the Ikeja local government area, Health District 6. Her professional experience gives her both the clinical and public health perspectives needed to have a meaningful conversation about maternal and child health. Today, she will be helping us understand how we can move from simply having policies on paper to actually putting those policies into practice, and more importantly, how every public servant can become a catalyst for better maternal and child health outcomes. So, colleagues, I encourage us to listen, learn, and perhaps even challenge ourselves to see our roles differently after this session. Mrs. Sonia Falabima, we are delighted to have you with us today. The floor is yours, ma'am.
Okay, thank you very much for the introduction. Good evening, everyone. It is my pleasure to be here, and I want to sincerely appreciate you for making out time to join us in this session. And I do hope that at the end of the day, it will be worth the sacrifice. Well, please permit me to also appreciate the organizers of this program, more especially in person of Mr. Jamil. He's been so supportive, and this is an avenue to make us know that we should not restrict ourselves to just the official assignments and what have you. We have a role to play in other aspects of life. So without further ado, please, I would like you to please project the slides so that we can start.
I think it's network from your side, or is it from my side? We can't hear you, ma. You can unmute yourself.
He was talking. I was able to hear.
Hey,
Yes.
Okay.
And she requested that you shared the slides. Okay, it's showing now.
Okay, can you see my slides? I'm sharing from my end.
Yeah, I can see it, ma.
okay, yes.
Okay. Our topic for today is from policy to practice. The public servant as a catalyst for maternal and child health in Lagos State's pursuit for SDG 3. And we are saying that this is a workforce-led approach whereby every public servant should, at the end of this discussion, be an informed practitioner and advocate for maternal and child health. Okay, as I've been introduced, I'm Mrs. Rashida Sonia Folabi, Health Education Officer from Ikeja Local Government under the Lagos State Health District 6. So the areas we are going to be covering tonight ranges from, we want to see what maternal and child health challenge is, and as well as the SDG. SDG is Sustainable Development Goals. We'll be looking at SDG 3 in Lagos State. Then the public servant as an untapped asset for health. Next is also to reframe the public servant's role, what we know we used to do as our role. We want to see how we can tweak it and also make best use of what we have. Then we'll be looking at the 9 action areas as regards practicing what we preach, as well as the challenges and enablers. And at the end of the day, we're going to have a call to action. So looking at the SDG 3, the SDG 3 targets general well-being. It says that to ensure healthy lives and to promote well-being for all, the emphasis all, and all ages. So it means that we are not leaving anyone behind, for all, at all ages. It commits to the World Organization as well as the UN Declaration, whereby we want to ensure we have healthy lives and well-being for all, maternal and child health indices ranging from antenatal registration, skilled delivery, immunization, postnatal care, insurance uptake, are amongst the clearest markers in this particular goal. Suffice to say that we have about 9 thematic areas under SDG 3. But for the purpose of this discussion, we will be limiting our discussion to just 2. However, in as much as they are interwoven, but we'll try as much as possible to remain within these 2 limits so that we do not over burden you. And with time, there can always be opportunity to discuss other aspects under the SDG 3. So the first one is the maternal mortality. It is expected that by 2030, we hope to reduce the global maternal mortality ratio to less than 70 per 100,000 live births. The second area we'll be looking at is the neonatal and child mortality. By 2030, we hope to end preventable death. The word there is preventable death of newborn and children under 5 years of age, with all countries aiming to reduce neonatal mortality to at least 12 per 1,000 live births, and under 5 mortality to at least as low as 25 per 1,000 live births. As we go on, please, I want us to pay attention to some of these figures I'm giving us so that there can be room for comparison. Let's take a spotlight at what does it look like in Nigeria? The maternal and child health indices. What is the data with the WHO? According to the World Health Organization, it says that Nigeria contributes to nearly 20%. I want us to also note that 20% of all maternal deaths globally. In fact, a Nigerian woman has 1 in 22 lifetime risk of dying during pregnancy, childbirth, or postpartum. Whereas in more developed countries, that we say advanced countries, the lifetime risk is 1 in 4,900. Should I take that again? For those of us in Nigeria, if you're a Nigerian woman, you live in Nigeria, we do everything in Nigeria. If we have 22 women, let's say in a room, the chances of one woman dying out of those 22 women from pregnancy-related complication is very high. The possibility that out of these 22, one of them will die from pregnancy-related conditions. Whereas if we were to cross to the other side of the world, you have to gather at least 4,900 women before just one will die from pregnancy-related complications or any form of conditions. So as we go on, you can see that this is becoming obvious that it calls for concern, and we cannot afford to continue to do things the way we've been doing it. In as much as we've been trying, but we need to look inwards. And that is the reason for us leveraging on this very wonderful platform. So why does this matter? Why the MNCH reality in Lagos State? What exactly is the reality in Lagos State? Member will say this is Lagos. Permit me to say, Ekolong Pebi. Some people will even say, Ayina Lagos. You know, we don't say welcome to Lagos. We'll say this is Lagos. Emphasis. Because we know what we have. We know what we are made of. This is a land where whatever you lay your hands on thrives. This is a land where you have virtually all the resources that can make anything happen. This is a place where we even have the population. We are talking about not less than 22 million people, yet we have the minutest land mass. So we should expect that in Lagos, we should be getting it right, right? And we shouldn't be having issues. We've seen the situation of what the way WHO has told us that 1 in 22, whereas in the other parts of the world, 1 in 1,000, in 4,900. So let's come down to Lagos. So despite being Nigeria's economic nerve center, Lagos still records preventable maternal and child deaths, which are linked to late caretaking, missed immunization, and low health insurance uptake. There's a study that says that 1 in 51 estimated lifetime risk of maternal death for a woman in Lagos. You know, when you talk about research, you have different studies at different times coming up with different findings. So it's not static, it is dynamic. But in all of this, we go by the the World Health Organization standard. It also matters because every avoidable maternal or child death reflects that there's a gap between the policy intent and our everyday practice. For the purpose of public health, where we operate, I would also say that our primary healthcare centers, in as much as it is not where it used to be, but we are not yet where we want to be. And a lot is really going on in terms of rehabilitation and renovation so that it can look more presentable and people can utilize the primary healthcare center. Having said that, let's look at the current situation in terms of maternal mortality in Lagos as a state. Lagos has progressed in improving maternal health, no doubt. In fact, we can use our hands to beat our chests that we have tried. But how well is this translating to the prevention of this preventable maternal death? In the year 2023, the Lagos State government, through the Ministry of Health, the Family Health Directorate, conducted a very massive survey, which was called the LACHIS, the Lagos Reproductive Child Health and Indicator Survey. So it was looking at the maternal health as well as the child health indices. So, and it was also a community-based survey. This was conducted less than 3 years ago, about 3 years ago. However, preventable maternal deaths still occur. That survey, or the study rather, showed that 430 deaths occur in a 100,000 live birth. Then most women who die experience delay in accessing appropriate care. So let's take note. We say they experience delay in accessing appropriate care. We'll be looking at where does those delay actually come from? What are the causes of this delay as we go along the presentation? So what is the recommendation from the World Assembly itself as far as the Sustainable Development Goal is concerned in relation to the Goal 3? They said that we hope to reduce maternal mortality to less than 70 deaths per 100,000 live births by 2030. We are already in 2026. So we have less than 4 years to go, and we are still recording this degree of mortality. So we hope that, okay, let's look at this. This particular survey, in fact, is very dear to my heart because I happened to, actually I had privilege of knowing when they started and some of the efforts that also went in. This is about the most recent survey. Recall that I reflected, or we looked at that of Lachis, said 430. This is a more recent, even though if you look at the time range, it's not far at all. So within 2 to 3 years, this graphical representation is letting us see our picture in actual terms, the reality on ground. Let me quickly say that these data were not generated from the facility. When we say facility generated data, we mean that those that utilize the hospital, whether the private or the public health facilities, and irrespective of whether it was at the primary, secondary, or tertiary level. These surveys, these researches were conducted right in the community where the people reside, where you and I, where we live. This is where the survey was conducted. And I think about 5,021 women were the people that were sampled and other things that had to do with pregnancy, those that were pregnant. And out of that pregnancy, we had people some that had multiple pregnancies. So at the end of the day, out of these over 7,000 pregnancies or unborn fetus or babies that we're expecting, we are going to see what happened to both the women and the babies eventually. So if you look at this graph, you find out that in Badagry, we have 4,210. 4,210, you know, after the survey, after the research or the work that was done, you now do a project. The specialists, the experts, they come in 10 in in 100,000, we have 154 network, 154 being out of 100,000 live birth. An average for Ikeja, 781 mortality cases out of that has been projected that every 100,000 live birth, there's possibility of having 781. Let's remember that these are not just figures, these are lives. It could be me as a woman, it could be you, it could be your sister, it could be your in-law, it could be your friend, it could be anyone, as long as the person is a woman. Even a girl child, that child eventually grows up in Nigeria. Remember, we said 1 in 121 females, one of them will probably die as a result of cases relating to maternal health, which is not what we pray for. So in as much as we are praying, this is the time to now do the work. So let's take a look at the slide here. You can see the graphical representation talking about stillbirth. Stillbirth, by stillbirth, we mean that the baby does not eventually become viable. The child did not survive. The child did not make it. So I'm going to try to simplify as much as possible. So sometimes it could be macerated, it could be fresh stillbirth, depending on when the woman presented in the hospital and other conditions that must have precipitated or that led to that woman losing that pregnancy. So this is also very
Sorry, it's like your network is freezing from there.
sure states.
Yes, I can no longer hear you.
I think it's network from our side.
Possibly.
Hello?
Hello, Ma. Your network went off for a while.
Yeah, I noticed.
Okay, Ma.
It's just a minute. Please, can you see my slide?
Yes,
Yes.
Ma.
Okay. So I was going to say that looking at this is Alimosho, where we have 120 stillbirth rates out of 1,000 babies. And that while we know that we're expecting 1,000 babies is because we run scan for these women. But Agege had the list of the stillbirth rates that was reported. So let's look at the causes. Now we know, we have said that, okay, this can happen, that can happen, the woman can possibly die, or the baby might not make it. So what are those causes that can actually lead to maternal death? We have direct causes and we have the indirect causes. So the direct causes, we have postpartum hemorrhage. What this simply means is that when a woman has been delivered of her baby, she has delivered her baby, everybody is happy, we are saying congratulations, and before you know what happens, it can be immediately after the baby comes out, or during, which is the second stage labor, or it can even be the third stage, which is usually commoner. Either the baby, the placenta does not come early, or the placenta eventually comes, we deliver the placenta, everybody's happy, all of a sudden the woman starts pouring and she'll be bleeding profusely. This is a major and is a direct cause of maternal death. The next one is preeclampsia or eclampsia. What this simply means is that in preeclampsia, as the word pre, it means that it has not become an eclamptic case, but at the same time, it's a life-threatening situation for the woman. So how does it present itself? This woman in labor, before she even falls in labor sometimes, while she's pregnant, You can have it that she'll start presenting with headache, persistent frontal headache. She can have what we call proteinuria, which is like they say there's protein in her urine. Let me just simplify it like that. Some ketone and the likes. Then she can have swelling, most times of the extremities. Usually it's more pronounced on the feet. At times it can be on the back.
We can't hear you again, Mr. Bolabi. Yes, I think it's bad network from my end. Oh, sorry about that. We
Okay,
can't
please,
hear.
so what's responsible for that?
All right, you are audible now.
Okay, sorry about that. So
Okay.
I was saying that in preeclampsia, it means the woman will present with two of any of the three symptoms or signs I've mentioned. One of it is headache. The second one is when we find protein in the urine. And the third is swelling of the extremities, usually the leg down to the feet. And any of these two shows that the woman is going into preeclampsia. Preeclampsia is when she could still be pregnant or it could happen while she's in labor. And it's a very, very life-threatening situation whereby she throws a fit, she convulses. Imagine a pregnant woman convulsing. Has anybody seen or heard of such a case? I want to know if you are following, if you are together.
Okay, you can raise your hand if you want to answer that. Any try? Okay, Adela Jadiruke say yes.
Okay, thank you for that response. So it's a life-threatening situation. And you can see we said that pre-eclampsia, eclampsia, it can happen either in pregnancy or in labor. And in rare occasions, it can happen immediately after she has delivered her baby and she throws a fit. It's an obstetric emergency. We should not wait for things like this. The next one is sepsis, which is infection. Infection, as little as it is, it can kind of degenerate and go to different parts of the body. That is what we call sepsis. Can affect different organs and the whole system. Such a woman, it's within few hours or even days, just find out that what happened now? She was talking to us, or she was saying, if time permits, we are going to look at some of those situations that leads to sepsis and eventually maternal death. Next one is obstructed labor. These, like I mentioned earlier, you can see that they are the direct causes of maternal death. When a labor is obstructed, the woman is in labor, she's trying to deliver a baby that she has carried for 9 months, and everybody is waiting to tell her, congratulations, madam, ekwe one more, only for her to be in labor 12 hours. And this is not her first pregnancy. 24 hours. Okay, let's say a primate, a person that is her first, and she keeps going 18 hours. One day, and you will hear her, she has been here since yesterday, and not Robbie, she has been trying to deliver since yesterday. Let's leave her, maybe because she's a primate. This is the first time. She has not done anyone before. It is not right. We need to ensure that we do not delay labor. Everything has stages, and that is why the importance of having to be under the care of a specialist. We are going to demystify we are going to look at those areas later. Then complications of unsafe abortion. We cannot but talk about this. And that brings me to the fact that when we are talking about that reproductive health starts from 15 years old. Women of childbearing age from 15-year-old to 49 years old. That's the brackets for reproductive age, women of childbearing age. So that means if you fall into this category and eventually the woman or maybe the lady or the girl goes try to want to abort a pregnancy for a million reasons, which we are kind of familiar with, if it's not properly done, it can lead to maternal death. And sometimes, even if it does not lead to maternal death, it can lead to infection, which we mentioned earlier, sepsis. The sepsis can eventually lead to the death. And sometimes in later life, it can cause adhesion, whereby when the retained products of conception were not well evacuated, it can lead to you have the uterine wall kind of adhering to each other. And at the end of the day, you find out that when it's not separate, there's no how the woman can conceive. And if she does, it can even lead to the pregnancy embedding itself outside the uterus, which we can lead to what we call ectopic pregnancy. Let's quickly take a look at the indirect causes. Severe anemia. Anemia means when there isn't enough blood. I'm trying to be as simple as possible. When they say the blood level is low, I'm sure we hear that from time to time. And the reason is not far-fetched. When a woman is pregnant, she's going to have to supply her own system and that of the growing fetus. And because the development happens, the most rapid form of development of the child happens in utero. So definitely the body is doing more work. It needs more blood supply. The blood supply, it is what we also take oxygen to that baby that is growing and the placenta to supply the nutrients for the growing fetus. So when this blood is not enough for the woman, not to talk of it being enough for the baby, it can also lead to complications and eventually death. Then malaria. Oftentimes, people always try to trivialize that after all, it's malaria. Malaria, there's nothing. For us in the medical line, we know that malaria is not just malaria, especially when the woman is pregnant. And that is why we cannot afford to sit back at home, especially for a pregnant woman, and say, you're a lazy woman now. Oh, what's office land? No, this is not your first pregnancy now. I had malaria, and so I won't say more than that. Let's continue. The indirect causes, heart disease. For people that have one heart condition or the other, they also have the right to conceive, irrespective of whether they have any form of cardiological problem. So now she wants to conceive. She probably did not consult her doctor, and eventually she's pregnant. She has to carry, and she wants to carry the baby to term. If the condition is getting deteriorated and is not properly managed, this can lead to her death. The same thing applies to sickle cell disease. Because of the rapid destruction of their red blood cells and other systemic conditions that they're exposed to, and the body has to do more work because of the baby the woman is carrying, that can also lead to death. So I want us to know that out of all these deaths that cases that I've mentioned, the direct and indirect causes, the most significant of it is that of the postpartum hemorrhage, which we said that when the woman delivers a baby and possibly the placenta too is out or is being delayed for some reasons, and the woman starts pouring, this blood loss, when it's more than 500 mils, such a woman, and is not properly managed, the uterus does not contract well, They do not manage it to know the technicalities on how to control the bleeding. And if at all they need to move the woman to the next level of care, such a woman can lose her life. Please, I want us to note all of this so that as we go along, we'll appreciate this discussion better. But I do not want to overflog some of these issues. And let me quickly mention that you'll be wondering, I've been mentioning direct causes, indirect causes, and some people will be like, oh, wow, that means when I have social condition, when I have general, is general hospital, his secondary facility, or the tertiary, which is either the LUF or LASUT for those of us in Lagos. So for the purpose of this discussion, we are looking at Lagos State. But I wrote something at the as a footnote that there are more advanced management of PPH in hospitals, even at the PHCs. I can tell you that for sure. At the primary healthcare level, we have that expertise to manage, especially when it's our own clients, that is the midwife or the doctor that is managing such a patient. If eventually there's a deviation from normal, they know what to do before eventually transferring such a woman to the next level of care. And we have measures in place in terms of how we refer our clients under our care to the next line of care. We do not just leave our patients like that. So what are the danger signs that we should look out for? I mentioned a few earlier, but these are the major danger signs according to the World Health Organization. Now, not necessarily preeclampsia or not, but danger signs that when a woman is pregnant, please, I hope you can hear me. I'm sorry, I don't know why my network is fluctuating. So seek medical care if a pregnant woman notices any of this. The first one is severe vaginal bleeding. Let me reiterate once again, it is not until when she's in labor, irrespective of whether she's in labor or not, when there is severe vaginal bleeding. But I will even say, you don't have to wait for it to become a severe vaginal bleeding before you seek medical care. By virtue of lived experiences, having worked at the bedside, I can tell you for free that when a woman spots, a pregnant woman spots, is telling you something, because she's not supposed to see blood. Her pants is not supposed to be stained. So if she assumes that it's just spotting, it's just small, and she leaves it like that, probably if it's coming from the placenta, it's detaching. You want to know, is it an abnormally situated placenta or even bleeding from a normally situated placenta? And if it's not well handled on time, it can even detach, and eventually the bleeding can lead to something else. So we should not overlook any form of bleeding. The next one is convulsion. I've mentioned that. Then severe headache, I've also mentioned that, and blurry vision, whereby the headache, yes, what also differentiates this preeclamptic sign. The headache sometimes find out that it comes with blurry vision. The woman will complain that I can't see very well, I'm feeling dizzy, I'm having severe headache, and the likes. Then high fever, when the body is hot, it's not only malaria that even causes fever. She could be incubating some infection, and so she needs to see the doctor. Difficulty in breathing, this is also very essential. If a pregnant woman tells you that, oh, I don't know, I'm feeling, or maybe she's even in the office at her desk and she's working, and she notices that I feel, I don't know, it's like I can't breathe well. We should not look away. We should not say, oh, after I'm not the doctor. Or start telling her that that is how he did me sometime, or that was what me too. I felt it like that before. Maybe you should use paracetamol. Maybe you should use it. You're trying to care. But at the same time, we might be getting it wrong. Difficulty in breathing is not something we should self-manage, whether in the hospital or not. And good enough for those of us in Alausa, because that is the seat of power. And that is where we have most of the ministries and the population of the manpower we are talking about. We have the staff clinic there. If you don't say, oh, the lift is not working, and before I will go, before I will start giving reasons. Oh, let me finish this work. Then she will continue. Because the pregnant woman, she's still moving around. You think that everything is fine. She might even have taken something that she reacted to, and she will not know that that is what precipitated the difficulty in breathing. And that is why a pregnant woman should not use drugs indiscriminately. She should not use drugs indiscriminately. Then also we have the swollen feet and face. I mentioned that earlier. Severe abdominal pain. By the time she starts having abdominal pain, it could be a sign of premature contraction, a premature labor. She should please seek medical care. Then also when there's reduced or absence of fetal movements, a pregnant woman ordinarily will feel the movement of her baby. She knows when the baby kicks. We call it quickening. If for any reason she is not feeling that kick, she should not assume that, maybe some people will say the baby is sleeping. Please, are we together? Are we still together? I want to know if my network is not fluctuating.
Yes, we are.
Okay,
Please, you
thank you
can.
very much, sir.
Yes, we are. All right.
So, and some people will say, maybe the baby is sleeping. Don't worry. Maybe you slept well, and so many assumptions, maybe this. In as much as we are not trying to scare you, at the same time, you should pay attention to your body. If you feel uncomfortable about it, can you please go to the nearest PHC? It's about the closest. In fact, whether you're working at the LGA, you're working at the ministry, you're working even Loma, anywhere, you always find a PHC, primary health center, closest to you. Even on weekends, even during the middle of the night, we have some facilities that run 24 hours services. Now, what are the 3 delays that lead to maternal death? Recall that I mentioned about delay as one of the major reasons for some of these deaths, and that now eventually leads to. The first one is delaying in seeking care. We've been saying this, ignoring danger signs like what we have just explained. Then also delay as a result of financial concerns, in addition to cultural beliefs. Our cultural beliefs, no doubt, culture, we are culture and culture is who we are. But nonetheless, there are some cultural beliefs that are negative. It is true we cannot say because we are practicing medicine, we'll say we should throw away those practices that we've been doing for donkey years. But if it's something that is going to be detrimental to the health of the woman and the baby, definitely we'll have to see how we can modify it. So I'm hoping that as we go on along the discussion or during the session of feedback, we'll look at some of those cultural beliefs and how it affects our level of seeking care. The next delay quickly is that of poor transportation in reaching the facility. When there's a delay, there probably access. We're talking about access to the place now. Maybe the place, the road is not good, or too many things can happen to the road. And at the end of the day, they cannot reach the facility, even though their facility is an edifice, but the road network is bad. Or possibly the road is good, but there's no vehicle to convey the woman from the house to the hospital, especially when she's in labor, or maybe when she has some of these complications or complaints, which we have mentioned earlier. Then also distance. Cannot overemphasize the effects of distance in people wanting to seek help or care, irrespective of whether we are feeling fine or not. And because of, by virtue of our health-seeking behavior in this part of the world, when we feel that we are fine, there's nothing wrong with us, or maybe this is not my first pregnancy, I'm fine now, I don't need to go to the hospital, I'm good. So that can also be a concern. Then delay in referral. Now the woman gets to the facility. On getting to the facility, probably the person they meet there did not know how to, the expertise wasn't sufficient. Probably there is no skilled birth attendants, maybe a midwife or a doctor on ground. And for whatever reasons, maybe for 1,000 reasons, it could be a public facility, it could be a private facility. So in the process of getting the diagnosis right, and also referring that woman on time that this is not our case, we need to move you. But as we are moving her, have we explained to her and the relatives have come with her while she needs the next level of care. That could also lead to maternal death if it's not properly handled. But let me quickly mention here in Lagos State, we have a robust referral system, a two-way referral, where when you refer a patient, when the patient comes to us, we fill the form, the patient takes it to the next level of care. There's another one they'll bring back to us to tell us what has actually transpired. Then also we have delay in receiving care. Now they are there, they have attended to her, but there isn't enough staff, or they say, oh, there's no blood, she will need blood. You know, we talked about anemia. That can also be a cause, or delay surgery. What can cause delay in surgery? Sometimes people are there, they tell the woman, oh, madam, the next thing is what we need to do right now. We need to put a knife on skin for the baby to come out. 2 to 3 minutes, your baby is out. And say, no, I need to call my pastor. I need to call my imam. I need to call my sister. Let them start praying. Obstructed labor, I mentioned it the other time, and other conditions that can lead to the woman not being able to deliver the baby herself, or it could be fetal distress. It could even be that the mother is even distressed herself. There's not enough oxygen going around to the baby is already distressed, and you are still saying you want to call someone. That could be another reason. So let's look at this. We said the public service. So this is where it's getting interesting. The public service, a workforce large enough to move the needle. Do we think that our number as a state, as public servants, is enough to make things happen or not to happen? Please let me see your emojis, or you could drop your message in the chat box. And if you want to mute yourself to tell us something. Are we together?
Yes, someone is typing yes.
So, okay, good. So it means that we have the population, we have everything it takes, we have the knowledge, we have the expertise, we have the energy to make things happen, and most times happen for the good reasons. And that is why we are called the Center of Excellence. So if truly we have been excellent in all spheres of life, in all aspects of it that you can think of, we are always the points of call and also reference points that you better go to Lagos, go and learn from. In fact, I was at work yesterday, and we're having a program that will have to do with trying to eliminate malaria, and we'll start spraying. We'll be seeing our people in the community from time to time. And the national coordinator of this malaria elimination program was with us. And the team was saying that their boss is here now. When they were in Abuja, should be, just using it to spite them. Say, you people should better go to Lagos. You better go and learn from Lagos. Better go and learn from Lagos. What are you people doing here? Let's start for Lagos now. This is Lagos. Are you in Lagos? I'm not seeing the clap. Oh. So they are using us as very good examples. So, and if that's the case, we have established that, yes, we have a workforce that is large enough to move the needle. So an average of 120,000 personnel in Lagos State Civil Service alone, not to talk of other parastatals that make up the public service. So, and of course, like I said, we are one of the largest organized workforces in the country. So the larger Lagos State's public service also includes the other sectors like I mentioned. So if that is the case, will it be wrong to say that each public servant sits in a household, an office, or an extended social network? That civil servant or a public servant that goes to work obviously lives somewhere, also socializes in different ways. If that is true, can we then say that what a public servant knows and is seen to practice does not stay with them alone? Obviously, the answer will be yes. It travels through every relationship they hold, because man is himself is a what? Is a social animal. We interact from time to time. These population segments is large enough to move our maternal and child health indices from where it is currently, and not merely delivering messages, not just the policies. Yes, there are policy statements, there are this, there are that. What can we do differently to make sure that we get it right? Oh, sorry, that's taking me back. I just want us to look at a broader view of what we have. So we are going to reframe our roles from just the messenger. Remember that we are public servants. So please, I crave your indulgence if I say messenger. It is just for us to be as simple as possible to another model that we think will work for us. Remember, we have established that the public service is a low-hanging fruit. Is a what? A low-hanging fruit, and we must do what? We must be ready to harvest it. We must be ready to harvest it. So let's look at the old framework. We have the external factors here as messenger. The public servant delivers campaign messages to the community, role limited to official hours and official channels alone. Then public servants and public service, we see anything that has to do with health separately. That one, this is work. Let's face work. That one does not concern me. It is the health workers. It is the health educator. Health educator will go and do it. We have 144 health education officers at the primary healthcare level presently. And we are the ones that are the grassroots. We are the ones that conduct community engagement activities, sensitization, mobilization, advocacy, and just like I'm doing right now. So imagine that to over 22 million population. So now what's the new framework we are looking at? We want a professional advocacy kind of framework where public servants do not just live in the, do not just see themselves as, okay, yes, this does not concern me. After all, I'm not pregnant. She's the one that is pregnant. After all, I'm a male. That's that my business. I'm not even married. Or even I'm married, my wife has finished delivering all the children. We have made up our mind that we don't want to have baby again. Does this concern you? Yes, sirs and ma'ams. One of it is that once public servants should be able to help us amplify the message by ensuring that people book early for antenatal, and also to extend the advocacy messages to friends and our relatives. And of course, we should know that because we are public servants, and remember, we are not just public servants, we are public servants in Lagos State, the center of excellence. We've got the credibility. And anything that comes from us, that emanates from us, most times people will want to believe and want to go by that. And when we practice what we preach, what we want people, where we want to be, if they see a civil servant or a public servant, okay, we're having an immunization campaign and the woman brings out her baby and she takes the vaccine for her child, definitely you see your neighbors also take. And you can even say, oh, after I've taken, that trust will be there. But if it now happens that it's even the public servant that is kind of skeptical about the services we render, or that is not comfortable with using or patronizing our health facilities, then I'm afraid we have a long way to go. So we have two roles, even though it's just one public servant. We are saying that we should be better informed. Yes, we're educated, but we need to be more informed when it comes to our health and also our responsibilities to the people around us. So in as much as we have narrowed this down to maternal and child health, you will remember that by the time we look at maternal and child health, it's like a gateway into other family health care services. Because if the woman comes to the facility as a pregnant woman or she brought her baby, there are other services which we call integrated services, which we can tell her about, ranging from family planning and other services like that. We can even encourage her. When last did you check your blood pressure? You can see that that's not only, and she's not pregnant. So that is not related to We can even also tell her that, oh, what of your husband? We can, based on the kind of relationship and the training we've got at the primary healthcare level. So we are saying that we should encourage women to register early, and they should register with the Lagos State Ilera Eco healthcare scheme. And also, in our households, I've mentioned that we should model what we want our society should be like. Then at the workplace, we should support pregnant women, our nursing colleagues, and we should also share verified information. Please, I want to really crave your indulgence at this point that these are very essential, in as much as I do not want to overflog it, but I must say that we have a critical role as stakeholders to ensure that we are supporting our pregnant women, those that are pregnant, and we should not say, after all, are you the first person that will be pregnant? Why, sorry, are you the first person that will be pregnant? Why are you saying, I want to go to clinic? You cannot go. You have to do that next time. You have to shake it in. If anything happens, you'll be held responsible. So it is essential that we give all the support we need. And for those of us that are pregnant, we should not say because we've had a training and they said we should pamper our pregnant women or nursing mothers. That is not to mean that we will now want to play trancy and assume that we can always say, I'm pregnant, I'm going to the clinic, and you will not go to the clinic. That's not what we are saying. We are talking about normal situation here so that we do not deprive other people of such benefit. Because if a boss or an immediate boss or manager is being considerate and is trying to give all the necessary support to the downline, that is not to mean that we now take pregnancy as a disease condition. No, it is not. So we should have that at the back of our mind. Now, the multiplier effects, like I've mentioned, for us as public servants, we have a life outside the workplace and even within the workplace. Imagine us just right in our homes. We can influence our relatives, our friends, our neighbors, our community at large, and even our spouses and extended family. So these are our own roles that we can do. So let's quickly take a look at the 9 action areas for the public servant. I said we should encourage early antenatal care, registration. This is important. And let me quickly mention here. And that time, okay, let me talk about a situation that happened where somebody called me and said, oh, madam, and it happened to be a day I was very busy. I was very, very busy that day. But I picked the call, and eventually the person was telling me, you got my number from one of the CAN leaders we work with. Okay, what's the issue? He said the wife wants to deliver. They've enrolled for a Ilera Eco, and at the end of the day, they said she's going to have surgery done, but they are saying that it's not covered because she has not been using a Ilera Eco up to 5 months. That was the first time I was hearing that, and that's why it's good to, when you interact with people, you can't know it all. You will learn on the job. So I was wondering that after all, the person has registered. I had to do a lot of calls, I had to make calls, and I was told that yes, that person has to have been using Ilera Eco for I think 4 or 5 months. I think 4 months, if I'm not mistaken, before she can be eligible to have that benefit of free cesarean section. So she did not register on time, and now she wants to have a C-section done. And they are claiming that after all, we are using Ilera Eco. They said it's going to be free surgery. It was a lot of stress for me, even though eventually we got it done. But next time, I told myself that I will not push such a push again because I will be encouraging them not to register early. And the people, the agency that has made it that way, they have a reason because we need to have your data and all whatnot. So it's essential. One of our take home here should be that every woman should register early. Immediately she notices that she's pregnant, she should not wait to the last trimester and okay, now they know people I'm pregnant now, so let me go and register. No, because if eventually that pregnancy does not go as planned and she needs to have a cesarean section, she will not have the opportunity of having the free CS. You will have to pay. So these are some of the messages we need to push out there so that they won't be saying, government is lying. Maybe your government, maybe you're working with the government. They are not saying what they are doing. So this is another take home for us. Then our messages, we see a lot, we are in the social media world. Most of us, we are seated next to each other. But before you know it, you find out that we are all pressing our phones. We are in another community. So the real community where it is happening is on the social media. The most common one is the WhatsApp. So when they push messages out, especially something that is not verified, please can you verify the messages before pushing and saying forwarded many times? The fact that it has been forwarded many times does not mean that it is a correct message. It almost messed up one of the state program we had about 3 years ago now, the human papilloma virus vaccination, where people were sending wrong messages. But good enough, the state revamped and we got it right and we nullified all of that. And in fact, we even ran out of vaccines. And that is the power of effective communication and making sure that we engage people. And that is why we are engaging all of you today. Thank you very much for staying with us. Then also we talked about prenatal and postnatal support for women. Before a woman becomes pregnant, it is advisable that she should know her health status, not that she just wake up morning. Even if this is not her first pregnancy, we should try to imbibe that culture. Let's know what our level is like before even conceiving, so that even if the person is on borderline anemia, that person would have been able to do what? Regig, whereby the doctor would have prescribed some imatinics for her to use, so that by the time she becomes pregnant, even if she has some of these minor illnesses in pregnancy, it will not weigh her down to the extent that it will even affect the baby that she's carrying. Breastfeeding, we cannot overemphasize this. This is very essential. People might see it as after all is to breastfeed. There are technicalities in breastfeeding, and the importance of breastfeeding cannot be overemphasized. It is not only because of the baby, it also has its effect, the health implication for the mother and also the family. Because of time, I really want to run through other. Then postnatal care, please permit me to emphasize here. Please, those of us in Lagos, whether you're a Lagosian by birth or by you're working in Lagos or whatever, we are all Lagosians, or we are all Amoeko. There's Amoeko and there's Areeko. Me, I'm Areeko, even though I was born and brought up here in Lagos. But then, all of us, this is speaking to us, both the men and the women, the grandmothers, the grandfathers, even those that are yet to get married. We should support postnatally. When the woman, yes, the baby is here, everybody is happy. We are thinking of want to do naming ceremony. They want to buy, the way we do our party here. Forgetting that woman. Sometimes a lot of these conditions go unnoticed because we are preparing for party. We are not saying we should not have party. Nothing says that the naming ceremony cannot be held. Maybe some other, I don't know, I'm not saying that our culture should not be followed or our religious practices, but we should also start putting the woman, it should be human-centered care, because not two pregnancies or deliveries are the same. So we should understand that and give all the necessary support. This is a period when, if not well managed, we have postnatal depression or psychosis in extreme cases. We also have blues. Some of them, the woman should not break down, she'll start crying, or she'll be shivering and the likes, or she's having a headache, or she's not sleeping well. Remember, this new baby needs to adjust to the extrauterine life. So the woman too will not be able to sleep. And she also wants to breastfeed exclusively for 6 months. It's a whole lot of work. Please, can I see the emojis for Lagos State? Can we clap for Lagos State government when it comes to the postnatal support that is being given for the women for 6 months to have our maternity leave, and also the men 2 weeks post paternity leave. It might be small, but at least it's something. Because this period is very, very essential. This is not the time, so, okay, you're on paternity leave, you're using it for something else. No, you should help your wife. You should support the women. This is not the time for the woman. She's the one that will cook all the food in the house. All the visitors that are coming, she's the one that will take care of them. She will forget to even change her perineal pad. We talked about infection, sepsis. Infection can come up from that if she's not talking take care of her perineum. The pad, the blood that still comes out immediately after delivery, and it's going to come like that. It changes, is in 3 phases until 6 weeks after she has delivered. If she doesn't manage it well, it can lead to complication. If she doesn't get enough support, and that's why you find out that you say, and she delivered, before you know it, she threw a fit or something, and she passed on. So this period is very essential. If you are given appointments, they will give you appointments, especially at the health center. They will tell you, even if you deliver in general hospital, or even teaching hospital, they'll tell you to come back. Please go back. Don't say after all, you're okay now. You're moving around. She's okay. No. What the health worker will see, you will not see it, because all we are seeing is joy. We are seeing a bundle of joy. So definitely we'll be clouded by other things, even though we do not pray for any complication. But let the health worker certify her that yes, you are good to go. And now we do home visits. We have our health workers, the nurses and midwives. They also do home visits, which we call the domiciliary care. The next, I've mentioned this, so I need to move fast. Then the next one is supporting the eradication of vaccine preventable diseases. I've mentioned that earlier. We are very big when it comes to immunization. And let me quickly say here that immunization is and has been proven to be one of the most cost-effective health intervention that is available as of today, as far as public health care is concerned. And that is why we are also craving your indulgence, that you should please vaccinate your children. All the vaccinations, our vaccinations, we don't collect a dime for vaccinating your child. So why would you not take it? And good enough, we are all public servants. So if you vaccinate your children, if you believe in immunization, and even we have adult vaccination, we have for 9 months, for 9-year-old girl child, the human papilloma virus vaccine. It prevents cancer of the cervix. Maybe some other time we'll be able to look at some of these conditions, and we're able to break it down and understand the way this thing works, so that we can address some of your concerns, and you will become better informed and be better advocates of why we need to push these messages out. Also, I've mentioned that we should normalize skilled birth attendance. It's essential. We should not say yes. We have seen cases, some people that are even doctors and nurses and the likes. At least I know quite a few. And at the end of the day, the person eventually did not make it at the traditional birth attendance. So what are we talking about? So irrespective of whether you're a spouse, you're a man, you're a woman, you're a grandmother, you're a grandfather, you're a young person, as long as you are within the reproductive age, you are appealing to your conscience to please, let's give science a chance. Let's give proven evidences and skilled birth attendants a chance. The data we shared with you were right from the community. These were extensive data gotten. We have what we call LVASA. We are going to get there. We should not say, yes, she can do it, and she has been doing it. We have a lot of cases whereby people do not go to the hospital, and eventually you find out that such, in fact, let me just say 1 or 2 cases. One of the cases was that a colleague of mine, then I used to work in Etiosa. She got to work that day and she was telling me, no, Sonny, did you see what happened? They just called me now, this, that. Our neighbor, that woman, she always take her delivery herself. She conducts her delivery herself. Her husband goes out, I think he said he's into construction. So he was not around. The woman was inside broad daylight, so in the afternoon. She locked up herself in the house there in Ajegule, and she conducted her delivery herself. And her children, she took the other children to be playing outside. Unfortunately for her, luck went against her, and at the end of the day, they were looking for her. When it was night, they didn't see anybody. So the children were still playing. They said their mommy told them to come outside to play. So they had to look for her. They broke the door in so that they could, only for them to see her corpse. She had delivered the baby right there. The placenta too was out. She was in pool of water and blood, and she had already died. This was first-hand information. Are we together, please?
Yes, we are.
Okay. The second scenario I'm going to paint is not even paint, it's what happened. I were having a meeting. In fact, this was in Ikeja. I invited one of the HODs who happened to be the HOD WAPA. Then, not now. So I was talking about this issue of maternal and child health and our role as stakeholders. We are all stakeholders. We should own it. So she said this, her neighbor called her and said, ma, she wants to deliver. You just help me. She was telling her that you just help me to do it like this. So yeah, I will do it like this. She was like, what do you mean? She said, I'm the one that usually take my delivery myself. Oh, I don't go to the hospital. The man was like, you don't mean it? So she said, with her position and authority and everything, she scolded her and she said she must go to the hospital. But this her neighbor refused. So she left. She was angry. She said while she was even trying to work out something what she could do, the woman had already delivered the baby by herself. Oh. After a while, she could not, her mind was not at rest. She went to check this woman. On getting there, she was so weak. She cannot just walk away and say, after all, I was telling you. She said she was the one that was even still running Elter Skelter to help her. But by virtue of that, yes, she's into WAPA. She knows some of the support she can give. And also, she happens to be a Rotarian. So it was at that day she also portrays what I was trying to say, that this thing is still happening. It's still happening, and we must. So this data we are getting from the community, from the survey, nobody sat anywhere to go and cook up data. There are evidences that shows that these things are happening. And those figures are not just numbers, they are lives. Until it happens to somebody before you know that, yes, it is not easy, but we do not pray for it. And for those that have affected in one way or the other, whether by error, omission, or commission, we only pray that God should console and support the family and the children they've left behind. I've talked about this slide, so I need to move fast. Then birth preparedness. What is birth preparedness? Yes, we have probably we have enrolled in with health insurance scheme, so we feel we are good to go. It's the government, they've told us that everything is free, and at the end of the day, the woman does not she does not make provision for the little items she needs to take care of herself and her baby. We have a lot of experiences on the job where some people will come. Even then, we used to give mama kits. We will give mama kits. At the end of the day, they will not even bring that pack that government gave them for free. They will not bring it when they're in labor. And that is why in some health centers, we encourage that when you are 7 months, bring your load, pack load, you put a padlock and you put it there. It's safe. So anytime she falls in labor, she just strolls in. So they check the item she has bought. Sometimes you hear people saying that their center, the list is too much. They're asking for this, they're asking for that. Nobody's collecting anything from them. But if you notice any malpractices or whatever you feel is not right, let us know. They are reporting channels rather than also amplifying those negative comments that will discourage people from using the government facilities. We've talked about early antenatal registration. We've talked that it is one thing to register. They should also make sure they attend the antenatal clinics. Some of them will just register so that when they say, have you registered in the hospital? They can say, yes, we have registered in the hospital, but that is not enough. Some of them will register in the hospital, and at the end of the day, they are still using TBA. We have a lot of them like that. In as much as we are not saying that they should not, we cannot tell them to forgo their culture, but they should know that there are some traditional birth attendants that are not trained. The Lagos State Primary Health Care Board is the one that they have a collaboration with the Traditional Medicine Board, and they try to train and to monitor their activities. And even the Lagos State Ministry of Health, I'm very much aware that they also check the training and also conduct some trainings for those that are trained. Well, what do we find? Excuse me, we find out that most of these deaths that happen in the community. Yet we that we believe that me, I'm educated, I'm a white collar officer. I cannot. What's my business with that? Even if they are delivering at home, after all, it's not. I'm not the one delivering at home. And you will not tell us that they are conducting delivery in that house. But at the end of the day, when something negative happens, everybody will start feeling bad. And they should also save money for emergencies. I told you of the scenario that happened. It was very stressful for me. So because she did not register early, but she felt that she can still have a C-section done because government will pay for us. There are usually terms and conditions that are associated with all of this. And also, we talked about blood group. When they register in the hospital, they would have checked all their baseline to know their blood level and everything that needs to be done. Let me quickly mention here that sometimes you have a woman who is incubating some 1 or 2 infections, and she might not even know. Remember, they say AIDS no dey show for face. Just the same way hypertension can be a silent killer. So she might be hypersensitive, she might not know. Or she knew she was hypertensive for whatever reason, she wasn't using her drug. Now she's pregnant. It can lead to preeclampsia or even eclampsia. And that can take her life and that of the baby. If she's HIV positive and she doesn't know, she's living her life, she'll infect the baby, she'll infect her husband. But if she starts taking drugs on time, if we do the baseline assessment, we detect on time, she will become, we give her what we call HARTs, the antiretroviral therapy, the drugs, and she'll be using the drugs. That will reduce the chances of transmitting the virus to her born child. When she wants to deliver, because she has a record with the hospital, the way they are going to deliver the baby, it involves some technicalities. It will also reduce the chances of transmitting the HIV virus while the child is trying to pass through the birth canal. Now the woman has delivered her baby. She wants to breastfeed her child, which is the gold standard that every woman, irrespective of whether she's HIV positive or not, they should breastfeed exclusively without mixing water or anything. If she did not register on time, there's no how she'll be able to get all of this information. The drugs that the baby will use, she will not know. Even the hospital will not be able to plan for the baby so that that HIV exposed baby does not come down with the HIV. But if all of this has been taken into consideration and she has gone through the treatment, I can tell you it's 100% success story. And that is what we want. We want a generation that will be HIV free and other conditions like even hepatitis B. It's very rampant now because we are not doing what we need to do. We feel that it does not concern me. After all, it's for me to go to office. Sometimes I'm guilty. So it is a collective responsibility and we need to get it right. The same thing with blood donation. We need to know that, okay, fine, just in case a woman will need blood, do we donate blood freely? We don't have to wait until because it is my labor, let's take it upon ourselves to do some of these things. They are humanitarian. And when we do this blood donation, fresh blood, we get better blood and we can live longer. I've mentioned about exclusive breastfeeding. So I'm going to go to the next slide. So driving the enrollment, I've talked about the Ilera Eco and why it is very essential. Even some people have registered, but they are not making use of it. And I don't know if it is obtainable at the secondary level, but I know that for those of us at the local government and even at the district, which also is being managed by the board, we now do our monthly audit with our policy number because the government wants to ensure that this policy that has been mandated that everybody should have the insurance done, the health insurance, is for our own good. That is the only way we can attain the universal coverage of health because you're going to pull the resources together and you can be able to benefit others. But if we, that even the government's officials, we do not believe or we do not trust the system, we do not trust the process, we are skeptical about it. How do we now advocate? How do we become models? How do we champion the cause? So what could now get on the way? Yes, we talked a lot about, yes, we should do this, we should do that. What could get on the way? And how can we help? What can we do differently? Sometimes at work, the workload is so much, you will not even remember the woman that is seated next to you is a pregnant woman. I've gone through some of this and I know what I'm talking about. Some people can be very strong when they're in pregnancy. So they will even forget themselves, but they'll be doing the work. And before you know it, God forbid. The way we say it generally, God forbid, please permit me to use that word, But we have to be more intentional and we have to be more observant of what is happening in our environment. When we see a pregnant woman, we should try as much as possible to pay their attention and encourage them to get some rest and to take plenty of fluids from time to time. Then I've mentioned about our culture. Yes, we cannot separate our culture from our level of education, but then can we be more practical about some things? And that's where we need to ask questions. Then, of course, I've also talked about trust. When there is no trust in the system, even some people that are working with the government, saying, please, and at the end of the day, directly or indirectly, people are hearing us, they are seeing our comments, our digital footprints is there all everywhere in the social media. So definitely, how do we now expect other people to key into what the government is doing? And that brings me to the issue of knowledge gap. When we do not have adequate information about what the situation is on ground, definitely there's going to be that possibility of being lackadaisical towards some of these services or even helping us to amplify the right messages. Then that brings me also to the enabling conditions, the enablers. What are those enabling situations? When the workplace is okay. And when I mean okay, I mean that when we start having health talks, we are having orientation on things that have to do with maternal and child health, not necessarily keyed into just our administrative roles. I've talked about breastfeeding, making sure that we have avenues that is conducive and good enough. Another thumbs up for Lagos State. I want to see the thumbs up. All thanks to the Ministry of Health, Lagos State Primary Health Care Board, and also some of our partners like the FHI 360. They conducted a project sometime which had to do with Alive and Thrive. And now we have some of these acts being implemented. Most places you have in the office space, whether the local government, anywhere. I know there are crutches around, and this has been very, very helpful for staff. So these are things we are talking about, that there should be enabling environments whereby the woman can breastfeed her baby, she can attend to her baby well. Then also peer education champions nominated. Used to be a very nice one. If we can have it across our MDAs, where we can have champions that will help us in also amplifying the messages. Then the messages should be simple, straightforward. We always say it's KISS. Keep it as short, as simple, and so that it can be easy for people to understand. We decided to go this far so that at least this is the first of its kind, and we want to make best use of the opportunity. Yes, we talked about the enablers. While I'm doing this, I'm sure we might have one or two people to say, no, if you go to the health center, don't mind them, they'll be singing, they'll be doing this, they are keeping us waiting. There's this, okay. But this slide up here was, I want to say a very big thank you to one of our permanent secretaries who was so magnanimous to share this with me. It was presented at the ECO Health Convention about, that was on Thursday. And when I saw this slide, I fell in love with it, because at a glance, it already told us that, yes, this is it. The district bringing services, healthcare delivery services closer to the people so that we can get it right. And you can see the indicators that we have achieved an increase of 30% level of satisfaction across the 6 health districts. So we are not doing badly at all. And if you look at the waiting time compared from 2023, the 2023 is the one in blue, and we have the other at for 2025. So if you look at the waiting time, it has reduced significantly. So if before now, if you were spending an hour or two in the hospital or in our facilities, now I can tell you that within 30 minutes or 40 or 45, you are good to go. So what is Lagos State doing differently? What are we doing? We've been saying, okay, we the staff, we should do this. What's on ground? If you know what is on ground, you know what you want to advocate for. You will know what you want to support. You will know what you want to drive. We are encouraging and we are pushing skilled-based attendants. And like I mentioned, they are training them, especially those that are registered. And we need you to help us to also give us those information that relates to those that are not registered, so that we can bring them on board. We are not, it's a no name, no blame approach that is being utilized. Then also the electronic medical records. Now we have better record keeping system, whereby you don't, even if you do not have your card with you, if you have your details, they can still trace it. But we encourage, at least we have not gotten there, but then we are not where we used to be. We encourage you to go with your card. But what I'm saying is that if you do not even have your card, that is not to mean that, oh, because I don't have my card, they're going to talk to me, they will not attend to me well, they'll tell me to go back. No, please, we now do medical records, which is electronic. Even our birth registration, we have e-registration for our birth certificates, and we do not also pay for that for children that are under 1. Emergency obstetric newborn care. This is Lagos State is very big on this. These are trainings that they keep going from time to time to ensure that we are at par with international best practices. The same thing with maternal and perinatal death surveillance and response. And this is one of the indicators. This activity has to do with checking from time to time, surveillance, putting our ears to the ground. Did anybody die? If the person died, what happened? What led to it? Is not, we are not prognosing. We just want to be sure, so that what happened, what led to that death? Was it something we could have avoided? Was it something we would have prevented, so that we'll get it right? We are not particular about, and she died with the TBA, or she died with, we want to know what led to the death. What would we have done differently? Was it at which stage of the delay? These are measures that are put in place. We call it community MPDSR. And we also have the one at the facility, usually at the secondary and tertiary facility. When anybody dies, they do not just, oh, she has died now. You say, those doctors, oh, what did you go? Those nurses, they are wicked. They do not, no, that's not it. We cannot be crying when you are crying. Don't let me tell you my story. But the truth of the matter is that an average healthcare worker is very compassionate. And that is why some of us decided to also still move forward and see how we can continue to champion the campaign. The maternal and child health centers, we've mentioned it, Lagos State has it all over. Then blood transfusion services, trust me, we have about the best when it comes to blood transfusion services in the country. Health insurance, I've mentioned that. Continuous training of our health workers. Sometimes you even go to our facilities. I'm sure one or two people can attest to this, where they'll tell you that, oh, maybe somebody, you ask for a particular nurse and they tell, oh, probably she attended to you, but you want to see her again. And so, oh, she's gone for a training. We keep having repeated training. Health education and promotion, this is what I'm doing right now, just to ensure that we are leaving no one behind and we are engaging as much as we can so that we can get it right. Routine data monitoring and management. Lagos State, of course, you are aware of the launch that was done recently when it comes to digital information and making sure that we are at par with global best practices. So what is our personal commitment for every civil servant? We have told you what the government is doing. And what do we need to do from this, all we've been saying? We have said that we should try to know the situation when it comes to maternal and child health, the facts, so that we can do what? We can take ownership. We should encourage antenatal and on time. We should not say the pregnancy is too small. It is when it's too small. Remember, that is when it's still forming. That is the formative phase. That is when development and growth is taking place. And it must be appropriate. Is it in terms of nutrition, in terms of the kind of, even as little as folic acid can prevent congenital abnormalities and complications. But if the woman does not know the importance of this thing, she will not use it. And at the end of the day, it becomes something that is irreversible. We've talked about immunization, we talked about antenatal and skilled birth. We also talked about verifying information. I'm passionately appealing about this verifying information. We want to make sure that you should fact check. We have the Ministry of Health there. That is one of the most reliable websites when it comes to government sources of information. You can Google, you can just go online, check what is obtainable, and you always get the most appropriate and reliable information in the Ministry of Health platform, as well as World Health Organization is there. You have UNICEF and other credible sources where we can get our information. Let's not be in a hurry to want to push information. Oh, they've said it forwarded many times. It has to be true. No, this should be one of our take home. Of course, I've mentioned Lera Eco, and I've passionately appealed that can we start today to start supporting pregnant women, whether at work, at home, in the community, wherever we find them. And for those that have been practicing, I want to say a very big thank you to you. Please continue to do the good work. Remember, we are all human. What we do, what goes around, comes around. I'm going to summarize by saying that during the household visitation across the 12-month reference period, that the data was collected. I mentioned earlier that 5,020 pregnant women were supposed to have delivered 7,217 live births. By the end of the day, look at this figure. Imagine, out of 5,020, 61 deaths, 61 maternal deaths. That is somebody's mother. That is somebody's sister. That was somebody's wife. And at the end of the day, 291 stillbirths. 291 stillbirths when she was waiting she wants to carry a bundle of joy. But because something was not done at the right time, we lost the baby and the mother, or any of the two. And the analysis yielded that a statewide maternal mortality ratio estimates of 833 per 100,000 live births and stillbirth rates of 38 per 1,000 live births. This is where we stand as of today, as against the 430. However, may I say, irrespective of whether it was 430 and what we have as 833 by 100,000 live deaths, live births, would we want to be in this data? Would we want any of our relatives to to fall under this data? Obviously, the answer is no. However, this is catastrophic, and we must not fold our hands and assume that it is none of my business, it does not concern me. And we watch it silently snatching our women and children away. I can say emphatically that it is doable. We have the figure, we have the data, we have the manpower, we have the resources, we can do it. I want to sincerely appeal to you conclusively that definitely we have numerous policies in place, which we have mentioned, ranging from hospital delivery, registering with LASHMA, and a whole lot. But we cannot do it alone. We cannot sit back and say, let them be doing it. Rather, we as the custodians of the system, we have a whole lot to do. Lagos State does not need to wait for MNCH indicators or indices to change from the outside. It employs enough people to change them from within when public servants are informed, when they are compliant and vocal. The multiplier effect of a workplace of over 820,000, is that not strong enough to reach the several more people? And of course, we will become a public health force moving Lagos closer to its sustainable development goal of the goal 3. On this note, I want to appeal to us. Let's practice it, let's model it, and let's advocate for it. Thank you for listening.
Can you please let your emojis come up? Let it come up. Let it come up. We are more than 100 on this call. I can only see only 2 participants that are appreciating our facilitators. I don't know you, but me, I'm learning new things today. Before, I think it's very easy to just give birth, but now I can understand. Thank you so much, Mrs. Sonia Folabi, for this insightful presentation. Thank you
Thank
so
you
much.
for the opportunity.
All right, so without not waste much of your time, because I know that you are still going to another corner after this. So quick one, let us go into the question and answer segment, which I will urge our participants to use the 2 type. It's either to use the chat box for your question or raise your hand up. Okay, I can see Adenike Ogutuashe. Okay. Okay, Adenike, you have the floor. Unmute yourself and
Okay.
in 2 minutes, please.
Thank you very much, Mr. Jamil, and thank you, Mrs. Sonia Folabi. That was very insightful. Dr. Adenike Ogutuashe. I'm the Director of Medical Services for Lagos State Health District 3.
Thank you,
And
madam.
I'm pleased with the presentation. I'm happy you can come to the civil servants such that even within our own, in Yoruba, they will say dogs don't eat dog. Within our own, they should own the PHC system and the services we render, and we should not have cases of death. I don't have any question. I just want to give my comment and to say a very big thank you to the presenter because she did justice to the job. Thank you very much and well done. Thank you,
Thank you,
sir.
Director. Thank you.
Thank you, Doctor, for that wonderful support and what to chip in again. So I can see in the, okay, Adenik, okay, it's Adelaja, you want to say something? Okay, Adelaja. Okay, you have the floor, Adelaja. Mrs. Adelaja, please.
Hello, hello,
Yo,
good
hello.
evening,
Good, e-
everyone.
good evening.
Good evening, my senior colleague, ma. I just want to give a thumbs up for Mrs. Afolabi for a job well done. She has really do a real justice to the MNCH. So I really want to just to appreciate her. Thank you.
All right.
Thank you very much.
Thank you, Mrs. Adela Jadirunke, for that. Any question? Okay, let me check the chat box to know if we have question. Well done, ma. Well done, ma. Well done, ma. Well done, ma. Okay. Thanks for that. Very insightful. Thanks so much. Okay, this one said, okay, I'm coming, Mrs. Shubeson. Seeing you there. Oh, I'm seeing something here said, this call for a continuous teaching so as to continue to be on track. God bless you, ma. Okay. Thank you. Very insightful. Okay. Okay. On a question and answer, someone was asking this question, said, what is LARCHIS all about? Are you there, Mr.
Okay, yes,
Folari?
I'm here. Yes, yes.
Okay, the acronym, the
So
person wants.
LACHIS is Lagos Reproductive Child Health Indicator Survey. So the survey was conducted by the Lagos State Ministry of Health under the Directorate of Family Health and Nutrition. So it had to do with getting information. It was like a household survey. So in the household survey, when they conduct household survey, they want to know the socio-demographic factors that predisposes to, okay, let me give for instance now, maybe when we have surveys, we want to know, madam, how many are in this house? The head of the household, we ask questions, we want to know if it's a nuclear or extended family, we want to know your average income and other things that will be asked. But you find out that sometimes some people might be a bit skeptical that why are they asking, why do they want to know? But you know that sometimes your income has a direct or indirect influence or effects on your purchasing power. And also that will determine the kind of quality of care you want to seek. So all of that is what is being done. Then for the children, we want to check for, they also check for stunting. Our children growing well, what is it? They went with measuring scales and also things to check their weight, their height, even to screen for malnutrition. There are other things that were done. Then also the women want to know their parity, how many children they have, how are they spacing the children. So there's a lot that goes into surveys, and that's why these questions are usually put together by experts so that I can actually address the situation on ground. So that was what the LACHIS was meant for. It's also similar to the LVASA I was making reference to. LVASA means Lagos Verbal Autopsy and Social Autopsy. So the verbal autopsy means that, verbal, we talk. You ask questions. Madam, what happened? Maybe somebody died in a particular street. You find some people come there, making it consists of the people from the health center, maybe the nurse in charge of the facility should have informed the medical officer of health. Then you also have the World Health Committee members in that community to inform us that we work with them as community informants. So they will not tell you that something happened in my community, somebody died, and you ask how old. If the man falls like 15 years, let's say 25 years, she already falls between the reproductive age. You want to ask more questions. What happened? Was it when she was pregnant? Was it that she wanted to deliver her baby? Was it that? So we keep asking questions. So that is the verbal autopsy. Up to the extent that it's like a root cause analysis, so that what happened then will not repeat itself. That's the whole idea. Then for the social autopsy, that family has given us information. We now want to ask the community again if it's a community effect, so that we can also mitigate it, so that we will not have a repeat of that such death in that community again.
All right, thank you so much, man. Thank you for that expo. Shogbeson Adeola, unmute yourself. You have 2 minutes.
Okay, good evening, sir. Good
Good evening,
Mr. Safari.
Sorry, re-unmute yourself, please. Sorry. Mrs. Shogbeson.
Okay.
All right.
Yes,
Sorry.
sir. Can you hear me, sir?
Yeah, clearly, ma'am.
Okay, sir. Thank you very much, sir. I want to say thank you very much to a colleague, and I want to thank the civil service for this program. And I want to say thank you again for the topic. It came up at this time that we are doing the commemoration of the World Breastfeeding Week. And at the same time, we just ended the program whereby children under 0 to 5 years were given vitamin A and other vaccines. So this is a learning for us as civil servants that in the state, in the primary healthcare centers, we have all services available for us to enjoy. So I want to say thank you very much for doing this. Even I, as a colleague, I learned a lot. And I believe this evening so many people would learn from here. I want to appreciate you and say thank you. Bye, sir. Over, sir.
Thank you.
All right. Thank you so much, Mrs. Sugweson, for that. I will call on Bakari Mustafa. Unmute yourself, Mr. Bakari.
Thank you, Mr. Facilitator. We feel blessed in joining this program tonight. A very germane word was spoken by our speaker that first of all, we have to market our product to others in order for them to buy into it. That is to say, to let the world know and the whole country know that the state hospital or Lagos State public hospital is very good for everybody to make use of. But however, how far are the team orientate the mindset of all members of Lagos State staff in order to advertise and sell the product in a way that other people will buy into it and have confidence in the service render from the system? Thank you, sir.
Thank you so much, sir, Mr. Bakari, sir, for your input, sir. Okay, I will call on Mrs. Badmos Kausara. Mrs. Badmos, unmute yourself from your end. Badmos Kausara, are you still with us?
Yes, I'm with you. Good evening, everyone.
Okay, good evening, ma'am. How are you?
Thank you. Yeah, I'm with you. Can you hear me, please? I'm very well. Thank you. Thank you very much for the insightful lecture, ma. God bless you. Well done. So, my question is actually majorly on reproductive health. Don't know if she can give me insight about that. So, like someone that is having issue with like fertility issue, like probably you tested positive, let's say a few days ago, but it was faintly positive. So maybe like 3 days ago, then 3 days after, then you now test it again, but it's not really negative. Like what can be the cause of that kind of thing? Though the person is actually having a fertility issue before, so but fortunately for the person saw like just of recent person tested slightly positive, but after few days again the person did the test and it went blank, so like it was negative. So I don't know, is there any insight you can give as regards that, though there are still other medical this thing, but I just want to bring it here as well, so don't know if it's
Okay. All right. Thank you for that question. In as much as I have my directors, one of my directors just spoke here. If she's still on ground, she'll also please say one or two things to buttress. But what I just want to say is that
Okay,
it's good you brought it up.
what's her name so that?
Okay, Dr. Ogutuashe, Dike Ogutuashe.
Okay, let me unmute
So,
her.
is she?
Okay. Dr. Nikema, you can
Okay.
unmute yourself and do justice to that
Good
for us.
evening once again. Well, the pregnancy test strips that we use at home is we use urine. We dip the test strips in urine, and there's a control. Usually, when it's positive, you see two bars. That is two red lines. So one
Okay.
is a control, which will usually be there, whether you are positive or negative, then the other one. But urine is just for you to check. At times, it may even show you positive. And when you get to the hospital and you do the gold standard, which is blood pregnancy test, not urine, then that is when you confirm that, okay, the red line you saw at home is really positive. So for some reason, there may be production error. It might be, like you said, it was a faint bar. It's not
Yeah.
a real positive. So it might just be a
Mm.
false positive result. You know, every test has its sensitivity and specificity. That means the rate of it being positive or the rate of it being negative. So it might just be a false positive at that time. What the individual needs to do is to
Mm.
do a blood pregnancy test. And also, since she has been having fertility,
Okay.
she also needs to go and see the gynecologist and do a workup so that they will know what the cause of the fertility issue is and treat her, then she will get pregnant. I hope I have answered your question.
Yes, you have, ma. Thank you very much. I appreciate
Thank
Okay.
you
that.
very
God
much, ma.
bless.
So
Yeah.
then on the wall, I also saw a question on hyperemesis gravidarum. That's when people
Okay.
get pregnant and they
Excessive
vomit
vomiting.
often. Yes, they vomit often. Yes, it's also a major cause, but it's not a leading cause of death in pregnancy. So that is why the speaker did not dwell on it, because if we want to bring the whole medicine of what causes death in pregnancy, you know, we will not live here today. So she's just dwelling on
In
the
fact,
common, yes, common things occur commonly, the common causes, things that you will be familiar with. That's what she has talked about. And somebody mentioned that there are PHCs in Ikorodu, some are far apart. We can't have a PHC everywhere. What the WHO standard says is one PHC per ward. Yes, we have not achieved it yet, but we are trying to get there. So we have seen it. We'll present it at the board level, and if they can give you a PHC, they will. Thank you. Over and out.
thank you very much, ma.
Thank you, Ma. Anike Abosede Rufus, you have the floor. Quick one. Anike,
Good evening, everyone. Thank you to my directors, my superiors, and my colleagues. Thank you for this opportunity, and thank you to the presenter. Okay, so my question is this: knowing fully that breastfeeding an infant with a mother that is HIV positive is a likelihood of is a risk factor for HIV transmission for the infant. So my question is this, and the presenter mentioned that using retroviral drugs for the pregnant woman can prevent transmission to the unborn child. So I just want to ask that what is the duration um, prior delivery that could trigger or facilitate um, at least a higher percentage of prevention for the infants from contracting the virus from the mother. Thank you.
Okay. Thank you for that brilliant contribution and question. For the HIV, let me quickly reiterate that the earlier we catch it on time, that we detect that this woman is HIV positive in pregnancy, the better the prognosis, both for her and for the unborn child, and eventually when the baby comes out. That's one. Then secondly, she will be taking the drug throughout the gestational period, throughout pregnancy. Then even when she's in labor, she will continue. So she's taking it for life. Let me just use that one. It's called HARTS, highly active antiretroviral therapy. She's going to take it throughout. That's one. And depending on the stage or as at the time when she got exposed to the virus, if she weren't pregnant and it was during this pregnancy that she's carrying, that she contracted that virus, the chances of transmitting it to the baby is higher because of the viral load. It will surge before dropping. So because of that, the chances is higher, and that's why she needs to even start treatment ASAP. But irrespective of whether she's been a known HIV positive patient or not, she will use it throughout. Then when she falls in labor, if there's anything I'm going to tell you, is the fact, for example, she must not, we do not rupture their membrane. The way you have, they'll say, they help me to burst my water. We don't do it for such cases. And a whole lot which we cannot mention here are some of the technicalities that are involved in managing such a case. And even if the membrane ruptures, which sometimes you don't have control over, it must not stay for more than 2 hours. There are other things we want to do to make sure that we actively manage the labor. And the baby that is exposed, there's a drug that the child, in fact, two, that the child will take normally, and she will continue, but she must never mix feed. If she mix feeds along the line, it will make the mucosa, the lining of the baby's abdominal wall, to become fragile. And as a result of that, the virus can penetrate and become transmitted to the baby. But sincerely, if she goes through a normal antenatal care with specialist care, the chances is very minute. It's usually 100% success rate or 100% failure rate. And that's why we're always very, very particular about early registration. I mentioned hepatitis too, please. Let me also say that a woman that is hepatitis B positive, if detected in pregnancy, they would have told her, even while she was pregnant, she didn't know, and she eventually, the moment we know, we tell her, and we tell her the vaccine she's going to also buy for her child, so that immediately she gets that one, the government does not give that one free because it's not common. It's an outlier, so we do not expect to be stocking that. But they'll give you the hepatitis B vaccine. That one is free. So she needs to take both as early as possible. She would have prepared her mind early enough to save towards it and get it delivered. So we give it to her. And most of the children, they come out negative. Because if it's not well managed, I hope you know that the end stage of hepatitis can also lead to cancer of the liver. So these are the reasons for early antenatal, and also making sure that they go through the process of the registration, not that they register with the government, they go elsewhere, so that when they ask, they say, I've registered with the government, but they are doing something else. The success rate will be reduced. Thank you. I hope I answered the question.
All right. Thank you, Mrs. Sunday Afolabi. Thank you, all participants. Thank you, Dr. Mrs. Ogunaiki, also for that contribution, and everyone that contributed to this call tonight. I've sent our link to the chat box. This is Public Service Knowledge Hub. This is a platform that you can get everything you need. Prepare for your promotion. Okay, Mrs. Itunu Babarende, you want to contribute? Okay. All right. Mrs. Babarende, 2 minutes, please.
Okay,
Unmute yourself.
Okay. Good evening, everybody. Good evening. Very insightful presentation. I just want to ask a question. Is there any explanation for the fact that maybe for someone's first delivery, that person had CS, and then subsequent ones, the person didn't have go through the C-section, or maybe the reverse, maybe the first 2 deliveries is normal delivery, and then the last one is CS. Is there any explanation for that, please?
Yes, okay, thank you very much. I'm going to use myself as an example so that you know that it's possible. Even the paramesis gravidarum that was mentioned, thank God my boss has answered that. I always have my paramesis gravidarum, but because I will not self-medicate because I'm a health worker, I will still be under the care of it, and I never had any complication in labor. So having said that, yes, a woman can have a C-section in her first, just like I had, and it might not be fetal distress. There are 1,001 things that can cause a woman to eventually, the labor is going on where everything is fine, 10 centimeter dilated, no problem. We now find out that at that point, it is because you're under the supervision of an expert. An expert is managing you. whatever they tell you at that point, you have to take it because you believe them and you trust the system and the process. So yes, she can have an emergency CS. So the baby can become distressed at any point. The mother can become, when I mean distress, sometimes you find out that the oxygen is not enough that is getting to the baby. You know, labor, that's why we call it labor. It's very stressful. And if the size of the baby is too big for the canal, for the baby, whether the outlet or the inlet, that can also be a problem. So, especially that's why you have sometimes you say primate because she has not delivered before. You don't know the way it is. Some places they will say, no, we want you to do pelvimetry. That's like a scan that will show the shape of the pelvis. So people have like a male pelvis. Some might have a female. So it's not by because you are fat or you are slim. So there are lots of reasons for a woman eventually needing a cesarean section. Then because of the reason, let me give an instance. If the baby were to be big, the first baby, it can even be maybe she had hypertension in pregnancy or diabetes in pregnancy. Like my boss said, we cannot mention everything here, but some of these conditions, when the baby is so big, or even is not GM, but for whatever reason, the baby is big or the pelvis is small, they will want to operate the baby, the pregnancy. The other one, if it's like a low-lying placenta, where the placenta, the position of the placenta within the uterine wall, if it's low-lying, you know that it's covering the cervical, the place the baby will pass. If it's covering that place and the placenta is sitting there, if you allow the woman to go through normal labor and it has obstructed the whole pathway, we are going to subject that woman to bleeding, and we don't want her to bleed excessively. Remember, we have talked about bleeding being one of the major causes of death. So there are a lot of things that goes on that they check in the scan. Sometimes it can be that maybe she's having what we call polyhydramnios or oligoamnios. If the water is too much or it's too small, that where the baby swims in the sac, the doctor will know when to say, at this point, this baby needs to come out. If the baby is not growing well, maybe it's small for dates, or sometimes you have intrauterine, which we call intrauterine growth. You want to be, so there's a lot. And that is why such a woman should see the doctor or the gynecologist. We advise, and most times, in fact, it's not most times, she has a right to know the indication for the cesarean section. What made her to have a CX in the first time? And there's what we also call trial of labor. If she had had a surgery before, depending on the cause, if it's not anything that is anatomical, she can still go for a trial of labor. So if she goes for a trial of labor and they find out that she's not making it, you can do a CS again. So it means that after that, she knows that it's cesarean section and she can eventually still make it. So different reasons for different outcomes.
Yeah.
What is most important is that the woman is alive and well, and the baby too is alive and well. So it's not a question of that she's lazy or she's this. After all, she has been delivering before. There are a lot of things that are associated with labor, pregnancy, and post-delivery.
Thank you.
Thank you.
Thank you so much,
Thank
Ma.
you very much.
All right. So on this note, I will call on Mrs. Anike Abosede Rufus to appreciate our facilitators and the Public Service Knowledge Hub. Before that, please, you can visit our YouTube channel. If you miss any part of this call, you can visit our YouTube channel and subscribe and watch the recap. And if you are preparing for your conversion, promotion, and what have you, go there. We have full public service rule and other things that you need to know to cover your promotion and other exercise. And also join our WhatsApp channel and the Telegram channel for more information. So thank you once again. Oh, Dr. Dorcas, we have exhausted our time. But okay, Dr. Dorcas, doctor, unmute yourself. You are going to do us two things after
Good
your.
evening.
Okay,
Good
good evening,
evening.
ma.
I'm not taking much of your time. I just
Okay,
want to
ma.
appreciate the presenter.
All
Yes,
right,
I
all right.
joined in very late, but I'm so happy and super proud of her. This is Dr. Dorcas Shonibere, retired director of nursing, Lagos State Ministry of Health.
Good
All
evening,
right.
ma. Thank you, ma.
God bless you. Thank you very much.
Thank you very
So,
much.
Doctor, just help us with the closing appreciation everything so that you can call it a day, ma.
Okay. Thank you very much. Actually, I didn't start with you to recognize those that are on the platform. But I want to
All
say
right.
on behalf of the presenter and the organizers, I want to appreciate everyone that took time to be on this platform this evening to listen to this fantastic topic that has to do with our mothers and their newborn baby. And just because it's because of the topic that I joined. So, and I believe that as we continue to talk more and more and enlighten the populace and with the cooperation of the health workers, the number of mothers that are in the big boat will reduce with time. Thank you very, very much. I'm very grateful for this opportunity.
Thank you,
Thank you,
ma'am.
ma. Sorry for
Bye.
joining.
When next
Bye.
are we meeting again, sir?
Okay, I've sent, okay, check the chat box, ma. You will see our, okay, let me resend the link. You can join our link, join our WhatsApp group. Then, since you came late, you can join, visit our YouTube channel, subscribe, and watch the program fully, ma. Okay, doctor, thank for that. Mrs. Avolabi, thank you so much. I know that you still have another call by 7 o'clock. So thank you everyone
Thank
for
you, sir.
for joining us. Ms. Avolabi, do we have any take home?
Sir?
Do we have any, maybe you have any take home advice or
Yeah, I
people
just
can.
want to say a very big thank you for everyone who has participated and also waited to the end of the program, and as well as those that could not make it. And I also want to appreciate the organizers, Mr. Jamiu, and the leadership of the Lagos State government for all they are doing for us. And it is my hope and prayer that we are going to walk the talk and we'll get there. Thank you, everyone, and have a
All
restful
right.
evening.
Thank you so much. Bye for now.